Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
Welcome back to another episode of Pod Patrol with your host, Dr. Jeff Dikis. Today, I am solo. I am by myself. Leland bailed. You know, I'm sure he has a good reason for it, but he's not all in on the podcast. He values his family and his kids more than a podcast, so that's certainly not the case for me. So I'm here, rain or shine, no matter what. But we wish Leland well and wish he was here with us, but he is not here tonight, and I am flying solo. So I thought we'd do something a little different and do a state of the podcast, a state of the union, where we're at. It's hard for me to know whether or not this is all worth it. Am I making a difference? Are people listening? Are they learning? Are they hearing things that make their brain engage? Is it making a difference? So I just got back from a conference in Salt Lake City, Utah. And when I was there, I presented. They were nice enough to, this company, to fly me out and have me present at their meeting. And when I got up on stage, I asked the audience how many people had heard the podcast. And I didn't know exactly what to expect. I kind of was bracing for, crickets and nobody had heard the podcast, but it was probably a little bit more than 50% of the people. And interestingly, I had my first fan experience. I had my first person come up and say, "Hey, you're Jeff from Pod Patrol, aren't you?" I was like, "Yeah, we got to get a picture together." So we took a picture. And so now I'm essentially Taylor Swift, and I know what it's like to be bombarded wherever I go. I can't even go out to eat without getting recognized. So I would say the podcast is growing. That's our goal. Get out there, help people make a difference in the world, spread the word, and try to help people, try to make a difference, try to educate some people. And it seems to be working, seems to be doing that. So we appreciate everyone's support. If you're listening to this, we appreciate you hanging with us through this, and we will continue to put out episodes. That's our plan. I'm thinking about firing Leland, just because he values the family and kids more so than the podcast. So, if you see a new podcast host hanging out someday, then you'll know what happened behind the scenes. We're also in the process of potentially hiring our first intern, so that's big news. Someone help with a little behind the scenes action. It's a lot of work, believe it or not, to put this on. There's a lot of time and energy and effort that goes into finding guests, communicating with guests, scheduling guests, putting together PowerPoint presentations, reading up on all their topics and all their CVs, everything they've done. There's a lot of time and energy and effort that goes into this. So it'll be nice to have someone kind of helping out behind the scenes. So I thought it'd be interesting today to kind of go through some of my most recent presentations that I gave, and not just listen to me drivel on about the state of the podcast, but learn something while we're at it. So we were out in Park City, Utah, which if you haven't been is unbelievable. It's awesome. We took the family out there, spent a few nights there, then went to Salt Lake City. One of my old co-residents is one of the attendings at the Intermountain Medical Center podiatry program there. So hung out with him a little bit, spent some time there. I would highly recommend getting out to Utah. It's beautiful. There's a lot to do. Super, super fun. All right, we'll kind of go through this presentation here that I put together that talks about first MPJ fusions and what the weight bearing status might be for first MPJ fusions, because everyone, I think, treats these a little different. We all know the reasons to fuse a first MPJ. We like to have these discussions with our patients about what can you expect when you go through this surgery and you end up on the other side with a joint that no longer moves. Sometimes those people start with a joint that doesn't move, so they're not going to notice much of a difference afterwards. Some people have decent motion and will end up with quite a bit different function afterwards. You're fusing it because it's painful, but they do have some residual motion there. So first and foremost, when I talk to patients, it's mainly pain. If you don't have pain, why are you here? What are we doing? So most of the time it's painful. There's an osseous prominence. There's cystic changes, sclerotic changes. The only people that I don't recommend a fusion would be anybody who kneels for their job. Sometimes that's a plumber, electrician, gardeners, carpet layers. There's certain professions that kneel more than others. And if they need to kneel for their job, I don't recommend this. And that may be someone who you might end up doing a joint replacement. Don't typically recommend that for patients. It's just not very reliable. Don't have tremendous outcomes. But if someone does rely on kneeling for their job, it may not be a bad idea to at least consider that, talk through the pros and cons of that. So these are the current trends in terms of hardware. Every time you turn around, there's a new company inventing something. We have staples, plates, screws, plaples. And then here I've invented scrates and scraples. So if a staple and a plate make a plaple, then can a plate with screws be called a scrate? And if those two get together, would it be a plaple plus a scrate makes a scraple? Ridiculous. Absolutely ridiculous, the amount of stuff that's out there. But despite the wide variety of stuff that's out there, a lot of them are designed to be innovative or better in some way. A lot of them aren't. A lot of them are the same thing. Not really innovative in any way. They're just different. But knowing what the options are that are out there, it's always better to know more options than less. The other thing to think about is, do we need biologics? When do we put biologics like bone graft, autograft, allograft into our fusion sites to increase the likelihood of fusion? This first study here looked at first MPJ arthrodesis, a systematic review of modern fixation techniques. They ended up having 277 feet, 96% union rate at about 83 days average union time. The staples, the plates, and the screws all healed in about the same amount of time. So what does that tell us? If you do a first MPJ fusion and you do a good enough job resecting the cartilage, you do good enough joint prep, the fusion will usually take. Things to think about would be underlying factors like diabetes, vitamin D deficiency, and smoking, potentially age, but usually those first three. But when you compare the types of fixation construct, even though they all heal, and they all heal about the same time, one of the things that we're thinking about now is, when can we let them walk on it? So the more stable the construct, the earlier you can let someone walk on it. This is a recent article looking at the new 2-plate construct. It's putting 2 plates across the first MPJ, 2 small plates across the first MPJ. And this study looked at utilization of 2 small plates as opposed to 1 larger plate. And they had significant complications. They had 4 patients, follow-up in 14 months, and they all had complications. Hardware failure, non-union, continued pain, and they ended up revising it with a much larger plate, plus or minus crossing screw. So this newer technique with these small plates, 2 of them, does not seem to be better than 1 large plate. The idea behind the 2 small plates is that it's polyaxial. It's getting better rotational stability, but I think you can obtain rotational stability certainly with different types of plates that have variable angle screws, and then crossing screws if you think that rotational stability is actually that important. But to me, counteracting the axial loading forces through the first MPJ with weight bearing is much more important than rotational stability. So how do we optimize fusion? So we know that we typically use locking screws in osteopenic bone, but what are the benefits of locking screws in a regular person without osteopenic bone? So to me, it's how proud those screws sit. If you use a non-locking plate, those screws bump up out of the plate. And on the top of the first MPJ, there's a lot of prominence there. They're going to feel it. It's going to rub. It's going to be uncomfortable. Whereas locking screws lock into the plate so the head is not proud and it sits flush with the plate. So despite someone not having osteopenic bone, I still use locking screws just so they don't stick up above the plate. So the ideal plate length is 3 times the width of the fusion gap. So if you're wondering how long the plate needs to be, Stoffel in 2003 looked at this. The ideal plate length is 3 times the width of the fusion gap, or sometimes you could be thinking of that as the fracture width as well. So there's different types of plates: 0 degree plate, 7.5 degree plate. I use a 0 degree plate. If you have too much dorsiflexion at the first MPJ of your arthrodesis site, of your fusion site, you can develop some IPJ arthritis, impingement, and some plantar sesamoid pain. If you have too much plantar flexion, you can lead to plantar IPJ pain. So when should we let these patients walk? There's multiple studies out there that support immediate weight bearing after first MPJ fusion. Now that's assuming that you use a stable enough construct to allow them to weight bear on it. If you're using crossing K-wires, remember back to the earlier study, no matter what you use, it'll heal. But I would not feel confident letting a patient walk on crossing K-wires versus a big beefy plate construct with locking screws with potentially a cross lag screw across your arthrodesis site. So I allow patients to weight bear in a cam boot at 1 week post-operatively. I see them at 1 week to check their incision, make sure it looks healthy, make sure there's no issues with it, and then I let them start walking on it in the cam boot. Like I said, the earlier the weight bearing, the more stable of a construct you'd like to have. So what does all of that information mean? Typically, it means that joint prep is probably the most important factor when it comes to getting a joint to fuse. Whether it be an ankle joint, a first MPJ fusion, a lapidus, triple, name it. Trying to get something to fuse, your joint prep is probably the most important because you can control for some of these factors: vitamin D deficiency, smoking, diabetes. Some of those things you can control, some you can't, but you can definitely control your joint preparation. So how do we get our correction across the first MPJ fusion site? So we know, according to Rugg in 2021, that a lag screw loses 30% of its compression after about 3 minutes. So how do we maintain the compression? So if we put a locking plate on, we can get compression through certain types of plate constructs and then lock the compression in with the screws into the locking plate. So as opposed to relying on a lag screw that starts to lose compression. Now, you can argue how much compression do we actually need across an arthrodesis site. As long as you have maintained stability, then maybe you don't need constant elongated periods of compression to allow healing. You can make that argument. But a locking plate that's going to dial in some of the compression and then hold it in place is what I prefer. The plate provides stability and prevention of the deforming forces, the axial loading forces that go through the first MPJ during push-off phase of gait. The dorsally placed locking plate counteracts those forces, allows for earlier weight bearing, and you're more likely to avoid construct failure. So let's jump into a couple cases here. This is a 62-year-old female with a large bony prominence there. That thing is out of control. Hop on the YouTube, take a look at this video if you want to see a wild first MPJ. Just all kinds of bone growing out of there. That thing looks like it's pregnant. It looks like it got together on Tinder with the second toe, and all of a sudden 9 months later, we got some questions that we need to answer. This thing looks pregnant. This thing is about to pop. All of this bone here is causing bony prominence and starting to cause a wound on the dorsal aspect of the first metatarsal. So what are we going to do about it? Well, obviously, we're going to resect the bone prominence, but then what are we going to do? This is pretty obviously a first MPJ fusion case. So this is a compression locking plate to provide some stability across the first MPJ. She had a good outcome. We resected the bone. But one of the issues, if we're being hypercritical here, is that I probably over-compress the first MPJ. So what does that mean when you over-compress the first MPJ? So some of these constructs, these new hardware techniques, are trying to get some compression across the fusion site. And the issue is that if you over-compress, it's going to want to dorsiflex the proximal phalanx on the first metatarsal. And you can see here, when we look at this, that I probably dorsiflex the proximal phalanx on the first metatarsal, and that's going to cause some impaction right here at the IPJ. You can see how that proximal phalanx head sits up a bit here and is potentially going to cause impaction when the hallux IPJ tries to dorsiflex during toe off late phase of gait. So if you overcompress, it's going to want to dorsiflex the proximal phalanx and lead to a bridging effect of the plate, which means it means the plate is bridging across as opposed to sitting fully flush all the way across the bone. It's actually bridging across. There's a little gap under the central aspect because it's compressed so much underneath that it's pulled the proximal phalanx up in the air. So you have to watch for that. This is a case of a 71-year-old female with a painful first MPJ, hallux valgus deformity, and it's painful when reduced. So this is pretty tried and true first MPJ fusion for me. She also needed second toe repair here. You can see some lateral deviation of that second toe as well. So what are the treatment options? Well, I go with a plate, and in this case, a crossing screw as well. So this is what I'm looking at intraoperatively. When I line up the plate. So first we're going to open it up. We're going to resect off the cartilage. We're going to get our joint prep as much as possible. I like the joint reamers, and then I'm going to microfracture with a 2.0 drill to stimulate subchondral bleeding across the arthrodesis site. And then I'm going to do my reduction, my manual reduction. I'm going to hold the first MPJ in the alignment that I want it to be, and I'm going to fire a K-wire across. I'm going to fire the K-wire from the center of the base of the proximal phalanx out, distal and medially, and then I'm going to fire it back across the first metatarsal. The benefit of doing that is that you know that the K-wire is crossing right in the center of the joint. If you start from the outside and you come in, you don't know exactly where you're crossing. It's a little unpredictable, or you get any good bite. But if you start in the inside the joint and fire it out and then back across the joint, once you've reduced it, you know that you're in the center of the joint. Once I've obtained my temporary fixation with a K-wire, I put the plate on dorsally and I temporarily fixate it with some BB tacks or K-wires. In this case, BB tacks. Then I take a few x-rays on multiple views to make sure that I like the alignment. I'm looking for the cluster of the holes that I'm going to fill with screws to be centered on the metatarsal and the proximal phalanx. So in this case, you can see it's a really good alignment of where those screws are going to be. And then I just drill and fill. I drill distally. I lock all those in. I use the compression device to get compression after I've backed out the K-wire. Backing out. If you leave the K-wire in place, it's not going to get compression because the K-wire is preventing your compression. So back out the K-wire part of the way, get your compression, fill it proximally, then drive the K-wire back across. Then you can decide whether you want to throw a cannulated screw across that K-wire or not. So here you can see the construct with low profile locking screws. You can utilize this compression tool, which is going to compress across the arthrodesis site as you use it and really allow you to dial in some of the compression. Once you've compressed across the arthrodesis site, then you lock in the screws proximally. Here's the final construct here. Much improved alignment. You have polyaxial fixation secondary to the alignment of the plate. Remember back to that other study where they wanted to obtain polyaxial compression or polyaxial rotational stability, I should say, with two plates. Well, in this case, you're obtaining multiple axes of stability because of the way that the plate conforms to the bone and it curves around, it kind of rotates. So you have screws coming in at different angles, which provides rotational stability. And then obviously the crossing screw provides additional rotational support and stability as well. This is another case of a 68-year-old female with a painful first MPJ. The first MPJ is asymmetric. You can see here when that joint tries to move, it's going to cause cartilage erosions. This joint is just going to be non-viable. She has a history of a Austin bunionectomy and a second toe PFJ fusion. The second toe was not painful, did not need to do anything there, but basically a failed Austin procedure with end-stage arthritis at the first MPJ with quite a bit of pain. So for this case, I elected to use a little bit longer plate. She had quite a residual increase in the intermetatarsal angle, so residual bunion with retained hardware. And when you have a more angular deformity, in this case, hallux abductor valgus, I tend to favor a longer plate that spans a longer distance and provides more stability to combat against the deforming forces of the hallux valgus deformity. So you have, in this case, the adductor hallucis is a deforming force that's pulling the hallux laterally, and it's a deforming force. When you fuse the first MPJ, the adductor hallux becomes a reducing force because it's pulling laterally still, but it's pulling the entire construct of the first ray because it's been fused, as opposed to just the hallux moving on the first metatarsal head laterally. So I like to use a little bit longer plate in a higher IM angle. I feel like it provides more stability and support because there tends to be higher deforming forces that cause the bunion in the first place. All right, this is the second presentation that I presented recently at a conference entitled Current Trends in Posterior Heel Pain. So we're going to be looking at different options for heel pain, which is a tricky subject. We're talking specifically posterior heel pain, not necessarily plantar heel pain. We're not talking about plantar fasciitis. We're not talking about nerve things. We're not talking about calcaneal stress fractures. We're talking only about posterior insertional Achilles tendonitis, osteophyte production, Haglund's deformity, things like that. So when we have posterior heel pain, what is causing the pain? Is there equinus deformity? Do we have a previous injury with some scar tissue formation? Is there bony prominence, which could be secondary to either of those previous two things, equinus or previous injury? Is there tendon dysfunction? Is it painful when utilizing the tendon? Is it painful at the insertion of the tendon? Is it non-insertional Achilles tendonitis? We need to figure out what the problem is before we can address how to fix it. We know that equinus causes significant issues when it comes to posterior insertional heel pain. So one of the ways that we fight against equinus is a gastroc recession. You can either do an open, like a Strayer or Baumann, or you can do an endoscopic, which is essentially an MIS Strayer. You're doing an Strayer. You're doing an EGR, an endoscopic gastrocnemius recession, at the level of the Strayer. You can see here on the chart, but you're doing it through a very minimally invasive approach, 2 small incisions. Another option would be a TAL, tendo Achilles lengthening. I do not tend to do those. It makes me nervous to increase the risk for rupture, which not the end of the world, but you've added on the recovery and healing time frame from an Achilles tendon rupture for this poor patient. So I don't favor the tendo Achilles lengthening. So when we start thinking about Achilles repair and osteophyte removal, are we going to do it open or MIS? And one of the newer / old ways, kind of a rejuvenated procedure that's old, is the Zadek procedure. We'll talk about that here in a minute. So this is a study out of my residency with a couple of my co-residents, and they looked at isolated gastrocnemius recession for treatment of insertional Achilles tendinopathy. Dr. Lowry, Tallarico, and Greenhagen. And this specifically was for insertional Achilles tendonitis. So they found that 91% of patients had high satisfaction and returned to regular activities. They did say that patients without an osteophyte did better than patients with an osteophyte. And in conclusion, the gastrocnemius recession alone, so no other procedures, just a gastrocnemius recession for chronic insertional Achilles tendinopathy, did have good outcomes. So this is something that I talk with my patients about quite frequently, because I don't think it burns any bridges. We know equinus is a driving factor of posterior heel pain, and if we can control the equinus, well, maybe their heel pain goes away. And this has a very fast recovery time frame. I'm going to do an EGR. I'm going to put them in a boot. I'm going to get them walking day of surgery. And the recovery time frame is weeks, not months, like some of the other alternative procedures. An alternative to the endoscopic gastroc recession would be a Baumann procedure. The benefit of the Baumann is that you can get in between the soleus and the gastrocnemius. And if you release the gastrocnemius fascia and you don't have enough dorsiflexion, you can turn your blade around and release the soleus fascia as well to get some increased dorsiflexion. So this is a case study here with a posterior heel pain, insertional heel pain. You can see that they have a Haglund's deformity as well as an insertional calcaneal enthesophyte. On this case, I did a midline Achilles incision with an inverted T to resect the Achilles tendon off of the bone. And when you do this and you're getting direct visualization of the Achilles tendon itself, you can see how thickened and scarred and nasty that Achilles tendon is. So part of the procedure when we take off the Achilles to access the bone, specifically the Haglund's and the posterior enthesophyte, is that we're going to debulk and we're going to debride the Achilles tendon as well. I typically debride and debulk about 50% of the Achilles tendon and take out a lot of stuff, specifically anterior to the insertion. So kind of more superior and anterior insertion of the Achilles tendon is what I tend to debulk and debride and get that out of there before repairing the tendon itself. I typically repair with fiber wire. So this is a case of mine that had a reaction to the fiber wire. So you can see on the left there, when that comes into the office and that's staring at you, that is not a good day. That is going to be bad news. So this poor patient had a reaction to the fiber wire, and it was starting to cause a soft tissue reaction and causing some degeneration of the tendon itself. I went in and I took out quite a bit of suture that was causing soft tissue reaction. And I ended up having to debulk quite a bit of the tendon there. You can see in that center picture, leaving quite a void of non-viable tissue. So after that, I kind of got it down to healthy tissue and then started reapproximating, not with a fiber wire this time, putting it back together with an absorbable suture, something like a Vicryl or a monocryl, something that's going to be absorbable. Even if they have a small reaction to it, it's going to absorb and dissolve with time, unlike fiber wire. And then sutured it back up and it healed almost instantly. So sometimes I see these and the patients have a reaction, or they're slow to heal, or they have kind of an incisional issue. And in that case, I'm worried about soft tissue reaction to the fiber wire. Not specifically fiber wire, but any of these big, bulky, non-absorbable sutures can cause soft tissue reaction. One of the newer ways people are tackling the posterior heel pain with insertional Achilles tendonitis is through an MIS approach. And so this is an MIS burr going in, resecting out the bone, and then releasing some of the tendon and then putting the tendon back down to bone. This doesn't make a whole lot of sense to me. Like we saw earlier, one of the main reasons we're going in and detaching the tendon and resecting the bone is that the tendon itself is non-viable as well. And so you have that thickened, scarred, nasty, non-viable tendon. We're going to go in, and part of the procedure is to debulk that tendon. Well, this MIS approach does not seem very easy to debulk that significant amount of tendon that I end up taking out of there. So I haven't tried this yet. I might try it in the future if I think that the tendon itself is not significantly thickened and is more of a purely osteophyte or genetic bony prominence issue, like a Haglund's deformity that I want to take down. Then I might try this procedure. One new spin on an old technique is the percutaneous Zadek osteotomy for insertional Achilles tendinopathy. So this is a study by Kaplan and Foot and Ankle International from 2023 that looked at doing an MIS Zadek. And they had a really good idea. So they took these K wires and they placed them laterally along the surface of the calcaneus and essentially created themselves a cut guide. you're going to be using an MIS burr. And an MIS burr, once it gets into the central portion of bone, is very difficult to keep in a straight line. The burr wants to just zigzag all over the place, wants to just chatter and move and fall back into the old hole that it was just in, as opposed to cutting new bone. It wants to fall right back into the old hole that it had just made 3 seconds ago. So putting these K-wires in there to create a cutting guide, I thought was a fantastic idea. So you align them exactly where you want your cut to be, and then you start sticking your burr in there. And you can see in that central picture there that it doesn't come out in a straight line. If you're expecting this to come out and look perfectly straight on both sides, from medial to lateral, posterior to anterior, I think that's not going to be highly likely. So you can see here there's a little zigzaggy nature to the osteotomy, which is okay. But what they recommended was going in kind of a quadrant. So 1, 2, 3, 4, 5, 6. You can see in the picture there, they have these little, I guess they're not quadrants because there's 6 of them, but each little area 1 by 1 and resecting the bone out. And so this is my case. This is a gentleman. He's 6'11", 375 pounds, a big old Iowa farm boy. So, and he has a few health problems. So the difficulty is when someone's that big, 6'11", 375 with some health problems, it's not going to be an easy patient to flip prone. So the insertional, detach, reattach, open procedure for me was going to be a last resort. I was going to try something else before I jumped to that procedure. So in this case, I talked to him about doing either an isolated gastroc recession or doing an MIS Zadek. And we talked about the pros and cons of both of those. You know, specifically the large nature of his Hagelins in that posterior enthesophyte. And I tell people, hey, if I do the gastroc recession, you're still going to have the bone there. It may not hurt as much, may not hurt at all, but you're still going to have a large bony prominence. And patients aren't usually too excited about having the residual bony prominence if they're going to go through surgery. So I talked about doing an MIS Zadek for him. So here on the top left, you can see my create a cut guide, where I put the K-wires in kind of just under the surface and laid them on the lateral calcaneal wall and created my own superficial cut guide. So these K-wires are laying on the lateral wall of the calcaneus in a V shape to take out the wedge of bone that I want to remove so that I can rotate the posterior tuber of the calcaneus anteriorly and a little superiorly as it rolls. So you can see here resecting out the bone and then rotating the posterior tuber anteriorly and then stabilizing with cannulated screws across the osteotomy site. So one important thing is to just verify that your screws are in the central tuber with a calcaneal axial. You don't want to be a little bit too far medially or laterally with your screws. So make sure, don't just rely on your lateral view when you're throwing these wires and subsequently your screws. You want to get a calcaneal axial, make sure you have good alignment there as well. So this is an intraoperative photo of the MIS Zadek. You can see those 2 little poke holes here at the very bottom. That's where I had inserted the K-wires. And up through the bottom of the heel to create the V cutting guide. And then you can see here on the side, I did the entire osteotomy through this small incision here with this burr, which is a calcaneal osteotomy burr specific for that. I started out at 6,000 RPMs, jumped up to 8 and eventually to 10. So this was the first time that I'd done this specific technique. So I'm still kind of finding my way when it comes to burrs and RPMs and how to hold your hand. Because one issue with this is you're getting a lateral x-ray when you're putting the burr in from the lateral side of the calcaneus pointed medially. You want to see where you are, but because your hand in the burr is in the way of your lateral x-ray, it's difficult to see. So you end up dropping your hand to try to get your hand in the burr, hand and the handpiece out of the way so you can see where the burr is. But that's not where it just was, because now you've dropped your hand and it's not exactly where you want it to be. So it's difficult to get a lateral x-ray and see exactly where your burr is when you're cutting. You almost have to kind of check it and then go for a little bit and then check it again. You end up using a lot of fluoro. And so, just like with anything, there's going to be a learning curve. The more you do it, the more feel you get for how bone feels when you've resected it. And there is a very different feel I found resecting cartilage, like when I do an MIS lapidus and I stick the burr in there and I resect the cartilage out. That has a very different feel than cancellous nature of bone in the center aspect of the calcaneus. The bone in the calcaneus is very soft. It's easy to just let that burr just go right through the bone. That's why having that cutting guide there, and as long as you're keeping your hand and the burr in the same plane, then you're not going to get off kilter and end up taking too much bone either posteriorly or anteriorly because of those K wires that are kind of guiding you. So you can see here the pre and post operative images of the MIS Zadek with the yellow wedge of bone being removed and decreasing the length between the posterior talar process and the Haglund's deformity from here to here. And you're essentially rotating all that bone anteriorly and decompressing it from being prominent posteriorly. So, we'll see if this is a long-term sustainable option. The benefit is that I could do this in about an hour through this very small incision right here and not burn too many bridges. If he ends up needing, more invasive surgical approach, well, we still have that on the table. But if we could save him the risk of having to go prone, specifically with his other comorbidities, and he obtains pain relief, I think that's a win. So those are the two presentations that I gave recently. I would highly recommend anyone get out to any type of conference they can, any type of local conference, online conference, Zoom meetings, anything that you can pick up and get some more information is always going to benefit you in the long run. So thanks for hanging out with us tonight on a State of the Union update episode of Pod Patrol with your host, Dr. Jeff Dikis. We appreciate everyone listening, tuning in, following along. Check us out on YouTube, like and subscribe, help us out. If Leland doesn't come back, then you'll know he got fired. So we may be having open auditions for Pod Patrol hosts soon. Leland, if you hear this, get it together. What's more important, podcast or family? Think about it. Thanks for joining us. We'll see you guys next time.